Distinguished Chairperson Senator Rogner, Ranking Member Senator Hicks-Hudson, other distinguished members of the committee, thank you for this opportunity to provide testimony for House Bill 68. As Senator Rogner mentioned, my name is David Bonnet. I am a board-certified physician trained in internal medicine and pediatrics. I have been in continuous practice for 25 years and currently practice in the space of hospital medicine and critical care. I have been watching this over time, and I am thankful to come to the committee. Over the next few minutes, I wanted to give you an overview of the history and the medicine that underscore the current issue of what is euphemistically called gender-affirming care. There are 3 points that I would like to make, and then I'll open myself up for question. You have my written testimony, and so I will try to do my best to be brief. This is my own testimony. I am not representing any professional medical society or employer. There is an ideological push, unsupported by science, that's underlying the urgency of gender-affirming therapies as they are being currently marketed. And as a result, a false narrative, which is dangerous, is taking root, which is that these therapies, which include but are not limited to puberty blockers and gender reassignment surgery, are as benign as penicillin and aspirin, as well studied as chemotherapy, and as essential to survival as insulin. I think that is false, and the evidence, which I will go over briefly, I think underscores that, and that is concerning to me. The medical literature with respect to gender-affirming care is incomplete at best and biased and poor quality at worst, and I will give examples of that. And the concern of that is that makes true informed consent impossible, especially for children who we've never regarded as having agency for these kinds of complex medical decisions. And lastly, I'll give examples of a number of pioneers of these treatments, both here and in Europe, who are now questioning this, and they are concerned about the observations they're making. But before I do, I'd like to share a story with you. I think it's illustrative of kind of the issues here. In 1876, at the Centennial Exhibition in Philadelphia, there was an unusual exhibition by a previously unknown British surgeon whose name was Joseph Lister. Some of you may be familiar with that name, Lister-Heen, right? So he was presenting data, 11 years worth, of an elaborate procedure which he used to improve post-surgical infection rates because he was addressing previously unknown microorganisms, which were not in wide understanding at that point. But unfortunately, despite 11 years of profound data showing plummeting surgical infection rates, he could not get traction in America. In fact, one surgeon was quoted as this, and I quote, "Little, if any, faith is placed in the absurd theory of Professor Lister by any enlightened or experienced surgeon, Dr. Samuel Gross." Now here's the thing. Samuel Gross wasn't just any physician. Samuel Gross was the president of the American College of Surgeons. He was one of the most well-respected and widely known physicians of his era. While Dr. Lister and his absurd theory are now the standard of care in every competent healthcare facility in the world. What is the point here? The point is here, regardless of renown, regardless of prestige, we can be wrong about this. Physicians and science is an activity undertaken by human beings, flawed, biased, and prejudiced as we are. So, what is the history? The history of this, basically for a large portion of time, was disproportionately a phenomenon of white, adult, middle-aged men with transgender. Over the intervening 30, 40 years, that has changed that demographic from middle-aged white males to adolescent females by a factor of 20. That's unexplained. Many of these females, as evidenced by the Tavistock Clinic in Britain, are now also coming with significant mental health comorbidities, psychiatric care. Indeed, one study showed from GIDS, which is the Tavistock Clinic, that as many as a third of these children presenting had autism of some spectrum. But to continue, how did we get from there to here? Well, because middle-aged men had endured puberty, undergone puberty, many of the permanent effects of that were present, and it made it very difficult for them to integrate authentically as the opposite sex. So the argument went, if we intervene before sexual maturation is complete, or indeed before it starts, all of that suffering will stop or can be avoided. Let me take a moment to say this phenomenon is real. Transgender people are real and they suffer. But they are in need and deserve real solutions. But we do them no favors by presenting to them false solutions, fads, and ideology. The last 2 points I'll make is the medicine that is underlying these efforts, these treatments, well-meaning though they may be, are seriously incomplete. An oft-repeated statistic has suggested that non-intervention risks a suicide rate among transgendered of 41%. There is no high-quality evidence supporting this. That particular number comes from a national transgender survey. The word survey should imply immediately selection bias. Randomized controlled studies of this have shown a much lower rate, while still significant, but conversely, other studies have shown no benefit from proceeding with a treatment. Indeed, at least one Swedish study has suggested that there is as much as a 19-time rate of suicide versus the general population at 10 years. So this lack of foundational evidence, misinterpreted conclusions, or misleading information used to support U.S. gender-affirming care is leading to genuine harm. Also, we have little to no information regarding the long-term consequences of these treatments, both physically and psychologically. But Dr. Bonnet, you might say, one study says this, but this other study says this. In your written testimony, you noted a citation that only showed 2 patients. And my response to that is exactly. That's the point. We don't know. In some places, the only thing that has been studied is 2 or 3 cases. Or maybe there is only 1 study. And when we're talking about this stuff, we're talking about what are the long-term consequences of fertility, heart disease, liver toxicity, bone density, surgical complications, sexual function. I could go on and on, but I won't. All of those are largely unknowns, and at least the study I mentioned before, many of those complications did not show up for 10 years. Most of the studies which we've looked at, any of these things do not follow patients past 4 years, suggesting there is a huge gap in what we know. In addition to that, many of the studies, the patients are lost to follow-up. If I have a cohort of 4,000 patients, and by the end of the study, I only have 1,000 of them, how useful is my data? It's not. Are they lost to follow-up? Did they commit suicide? Have they quit engaging for some reason? Did they detransition? In the original study on which all of these studies are based, which was referred to as the Dutch protocol, it was a study by De Vries in the Netherlands. It was a very specific group of people that were studied. Young boys who had always identified as girls. They got 6 to 18 months of intensive psychotherapy. If they still wanted to proceed with puberty blockers and surgery, they did so. And by all accounts, they did well. But over time, significant problems, even identified by Dr. DeVries herself, identified significant problems with that study. Bias, loss to follow-up. Those are what we refer to in medicine as confounders. Pieces of information, either by their inclusion or by their exclusion, confound the data and invalidate your results. Lastly, I'll say this. There have been several people, prominent people, who have noted concerns with this data. Notably, Dr. Paul McHugh, psychiatrist in chief of Johns Hopkins, who stopped these therapies when publishing with his own department showed no benefit. By converse, Dr. Ritu Kaltiala in Finland, who was one of the early proponents of this in Finland, creating the first gender clinic there, enlisted the Council of Health in Finland, known as COHARE, a study in 2018 to investigate these studies. In 2020, they released their results. Let me quote, "In light of available evidence, gender reassignment of minors is an experimental practice. Young patients seeking gender transition should be instructed about the reality of a lifelong commitment to medical therapy, the permanence of the effects, and the possible physical and mental adverse effects of the treatment." The report further warned that young people whose brains were still maturing lacked the ability to properly assess the consequences of making decisions they would have to live with for the rest of their lives. And the authors concluded that for all these reasons, gender transition should be postponed until adulthood, and so they did. And so too, 3 years later, did the British. That investigation was led by none other than Hilary Cass, one of the most respected pediatricians in Britain, president of the Royal College of Pediatrics and Child Health. Her report concluded the same. The report highlighted a profound lack of evidence and medical consensus about the best approach to treating gender dysphoria in children. Yet, the NHS's Specialist Gender Identity Development Service took a child's expressed gender identity as the starting point of treatment and could not be questioned. This affirmative approach left little space for exploration of the potential relationship between their dysphoria and neurodiversity or psychosocial needs. So what are we to say about that? The opponents of this would have you believe that those people are transphobic, science deniers. These are some of the best clinicians in the world. No, of course we wouldn't. To do so would be absurd. So I will leave you with this. 70 years ago, the most celebrated treatment, new treatment for mental illness, schizophrenia, bipolar disease, even major depression, was to cut out the front part of the brain. Cut out the front part of the brain. And every single person who performed that procedure, numbering, by the time they abandoned the procedure in the 1980s, numbered about 150,000. Every single person would have told you they're helping people. They're protecting people. They were wrong. And indeed, the guy who invented it, Antonio Muniz, a Portuguese neurosurgeon, got the 1949 Nobel Prize for Medicine. Today, somebody would perform that procedure and we would put them in jail. Appropriately, we view this as monstrous. Why do we know this? Because we continue to get scientific evidence that shows no benefit and shows significant harm. When I graduated from medical school, one of my medical school professors said, he compared us to primates flying the space shuttle. We knew enough to flip a few switches to get cause and effect, but we didn't know the totality of what we were doing, you know? And although that's hyperbole, the lesson was very clear. Don't be arrogant. Don't think you know what you know more than you do, because if you do, people get hurt. Transgender individuals are real. They suffer. They deserve community, dignity, compassion. What they do not deserve is fads, ideology, and certainly not grotesquely optimistic false promises that are unsupported by science. Let's not repeat the mistakes of the past. That's all I have. I'll be delighted to take questions.